Hello students, in today's lecture we are going to talk about the anti-psychotics. These two movies and many other movies has a center topic about schizophrenia or a psychosis. So let's see what is psychosis and what is the antipsychotic drugs. Now, if you have tried to study the antipsychotics and you have find it very difficult, then I promise you, after this lecture you will find it easy and simple. Let's start. In today's lecture, we are going to see what is psychosis, what is problem in psychosis, how we treat the psychosis, and what are the complications of the treatment. So, first question, what is psychosis? Psychosis is generalized psychiatric term. In medical college, we have very common terminology, psycho. If someone is so busy with his study that he doesn't know what is going around himself, then we say he is psycho. So the term is actually little bit correct. The real meaning of psychosis is loss of contact with the reality. It is general psychiatric term means loss of contact with the reality. So if person is not able to identify what is reality and what is the world in his own mind, then it is called psychosis. Now, particular disorder is schizophrenia, which is very commonly we sometimes refer as interchangeably with the psychosis, but that particular disorder is schizophrenia. There are other psychiatric disorders are as well: depression, bipolar disorder, OCD, phobia, and anxiety. So schizophrenia is one of the psychiatric disorder. But the thing is, in case of schizophrenia, patient doesn't have insight. Patient himself doesn't know that he has a problem, and he is not willing to accept that he has a problem. And not only that, there are certain symptoms which makes it more difficult to treat. So some important general points about these antipsychotic drugs, that they are useful in multiple psychiatric disorder. Many antipsychotic drugs are also useful in the depression, in the mania, and some other psychiatric disorder as well. So they have more than one use in psychiatric illness. Second thing, they are not very specific when coming to target. They block multiple receptors, and that is why they also produces many side effects. And general pharmacokinetic property of the all CNS drug also applies here. I have also told it in my pharmacokinetic lecture as well, that to be effective, any drug which is used in CNS has to reach till the brain, so that it has to cross the blood-brain barrier. To able to cross the blood-brain barrier, it has to be lipophilic, and if it is lipid soluble, if the drug is lipid soluble, then it has a very high volume of distribution, and if it is having high volume of distribution, then it is going to have a long TR, and usual dosing is once a day. So this general property, pharmacokinetic property of any CNS drug also applies to antipsychotic drugs. Now coming to the specific disorder, schizophrenia. Schizophrenia has a two type of symptom, broadly divided: positive symptom and negative symptom. Positive symptom means something which is produced without actual existence, like delusion, hallucination, and disorganized thought. Delusion is believing something which is not true, and it cannot be patient cannot be made understood it even by logic. So if we believe in the God, is it delusion? No. A particular delusion should not be related to religion or common belief, like God or evil or ghost. Okay, that is acceptable. But delusion that my friend is trying to kill me or society is harassing me, just that type of delusion, that is called delusion of persecution. Someone is trying to harass you, or government is trying to kill me or punish me. Such type of delusion exists in the mind of patient, and we may try to explain it so many ways, but patient will not believe ourselves. He will keep believing whatever he is believing. So that is the delusion. Hallucination is seeing or hearing something which does not actually exist, like seeing something which is not there, or hearing a voice which is nobody is speaking. So particular which example I give you, the cardiac movie, the patient was receiving a call which was just his own hallucination. Actual call was not coming, but he was able to hear the call and was also talking to someone. So that is the hallucination. Auditory hallucination is quite common in schizophrenia, whereas visual hallucination is not common. Visual hallucination usually occurs with consumption of the illegal drugs, cocaine, heroin, methamphetamine. That type of drug produces visual hallucination. But in case of psychosis, auditory hallucination is quite common. Patient continuously hears someone commenting on each and every action. So patient feels very much harassed because someone is continuously commenting on him, and he can continuously hear that auditory commentary. And disorganized thought. Person's thought is not very much organized. Patient is talking about something currently, and he immediately jumps to some another topic, then again it jumps to some another topic without any relation in between the topic as well. So that type of disorganized thought is common in schizophrenia. So this is the positive symptom. Now, negative symptoms include the loss of interest in surroundings, social withdrawal, lack of motivation. Person isolates himself, and he is not very much getting involved in any of the activities going around. So that is the negative symptom. So positive symptom and negative symptom seen in schizophrenia. Now, why we are talking about this symptom is very important to understand its pathophysiology. Exit pathophysiology, what is the problem in the psychosis or schizophrenia is not clear, but scientists have rough idea after various drugs which are producing various responses in psychosis. So to understand the pathophysiology of the schizophrenia, we have to understand the dopamine trap. Now, it seems very difficult, but believe me, if you remember this thing, you have learned the antipsychotic. This is the only slide you need to remember, and antipsychotic become very easy after that. So dopamine has a 4 different circuit, actually 3, which immediately become the 4. First track is mesolimbic and mesocortical tract, which is highlighted here in the blue, which then divide into the mesolimbic tract and mesocortical tract. Second track is the nigrostrial tract, the same tract which you have learned in the Parkinsonism, and which is responsible for fine movements. And third tract, which is important, is tuberoinfundibular tract, which is basically a very short tract by which dopamine regulates the release of prolactin in the body. It is particularly useful to control the release of prolactin. Dopamine basically inhibits the release of prolactin. Now let's see what this tract are doing. Mesolimbic and mesocortical tract, this tract is particularly involved with the higher function, motivation, memory, emotion and cognition. Nigrostrial tract is controlling the fine movements, and that is why when there is dopamine deficiency in this tract, it leads to Parkinsonism. This leads to Parkinsonism. So nigrostrial tract is responsible for controlling the fine movements. Tuberoinfundibular tract, as I told you, it inhibits the prolactin secretion. So this is the summary. What is problem with the schizophrenia? In the schizophrenia, the first 2 tracks, mesolimbic and mesocortical tract, there occurs a dopamine imbalance. Dopamine increases in the mesolimbic circuit and it decreases in mesocortical tract. It increases in mesolimbic tract and it decreases in mesocortical tract. Now what it does there, when dopamine increases in mesolimbic tract, it starts producing positive symptoms like delusion and hallucination, dishonest thought. All these occur because of increased dopamine in mesolimbic tract. Decreased dopamine in mesocortical tract lead to negative symptoms: loss of interest in surrounding, loss of interest in social gathering, and patient become isolated. There is lack of motivation. All these occur because of decrease in dopamine in mesocortical tract. So imbalance in dopamine in these two tracts is ultimately responsible for all the problem in case of the psychosis or schizophrenia. Now what happens that positive symptom which lead to delusion and hallucination make patient think that somebody is going to kill me. Even the doctor who is giving him a medication, he thinks that it is some sort of poison to kill me or to make me to have some problem with me. So he tries to refuses it. And in the road, if you see some of the mad people going on, they try to throw a stone at the random person. Why? Because he thinks that he is someone my enemy. So these positive symptoms are the symptoms which are actually producing a problem, or which actually come into the notice first. So initial target was to treat these positive symptoms. These positive symptoms are biggest problem. This delusion and hallucination are biggest problem in case of psychosis. So that is how we try to target. Now two other tracts, nigrostrial tract and tuberoinfundibular tract, that doesn't have any dopamine problem. The dopamine level is quite normal in this tract. The only problem is with mesolimbic and mesocortical tract. Now, current treatment strategy, what typical antipsychotic drug does, that it try to block the dopamine receptor, particularly dopamine D2 receptor. So overall effect is it decreases the dopamine level in all the pathway. It decreases the dopamine level in all the pathway. They are dopamine antagonists and they decrease the dopamine level in all the pathway. Now initially I told you that these drugs are not very specific in target. So apart from dopamine, the leftover drug which spills in the surrounding area, which is rich in many other receptors, they are also blocked. Like cholinergic receptor are blocked, histaminic receptor are blocked, adrenergic receptor are also blocked. So they are dopamine antagonists as well as there are anticholinergic, antihistaminic and antiadrenergic effect. These all type of effect are seen in the drug. So what will be overall effect? Let's see. In mesolimbic tract, the dopamine become normal, so positive symptom improves, because that was the problem. But in mesocortical tract, in nigrostrial tract and tuberoinfundibular tract, in all other tract, the dopamine level decreases. In all other tract, dopamine level decreases. So what will happen in mesocortical tract? Decreased dopamine level in mesocortical tract was responsible for negative symptom. Now it further decreases. So negative symptom worsens. Negative symptom worsens. Person become furthermore isolated, furthermore silent after the treatment. In nigrostrial tract, now it was previously normal, but now it decreases, which lead to Parkinsonism like symptom, which is called extrapyramidal syndrome. Extrapyramidal syndrome or drug induced Parkinsonism. Not only Parkinsonism, there are many other things, symptoms like Parkinsonism occur due to decreased dopamine in nigrostrial tract, because it is controlling the hind movement. So it is all as such called extrapyramidal symptom. And then in tuberoinfundibular tract, which was inhibiting prolactin, now it is not inhibiting prolactin, so prolactin level increases. So increase in prolactin level lead to hormonal symptoms, like increased prolactin level can lead to galactorrhea, it can lead to weight gain, it can lead to amenorrhea, and so many other hormonal problems, infertility, loss of libido. So many problems can occur with this increased prolactin in tuberoinfundibular tract. So overall effect, in the mesolimbic tract, dopamine become normal, positive symptom improves. But negative symptom worsens because in the mesocortical tract dopamine level is decreasing. Same way, dopamine level is also decreasing in nigrostriatal tract, so Parkinsonism like symptom occur. And in tuberoinfundibular tract, dopamine level decreases, which lead to increased prolactin level and hormonal symptom occurs. Parkinsonism and the psychosis are kind of on the opposite end of the disease. Parkinsonism occur due to lack of dopamine, whereas psychosis occur due to increase in dopamine. When we give the drug for psychosis, Parkinsonism is a side effect. When we give drug for Parkinsonism, levodopa, if you remember, one of the side effects of levodopa is psychosis-like symptom. So they produce opposite effect to each other and produces problem like a side effect of each other diseases. So how we are treating psychosis? We are giving dopamine antagonists, and we have seen whatever effect occurs due to dopamine antagonism. Now, apart from dopamine, it is also affecting other receptors. So that side effect also produce. So in case of anticholinergic, they produce this anticholinergic effect. So side effect of anticholinergic drug are also seen, like dry mouth, constipation, difficulty in urination, and mydriasis. But it also has one advantage. In case of extrapyramidal symptom or Parkinsonism also, we give central anticholinergic drug. So this anticholinergic effect, the drug is having predominant anticholinergic effect. It is somewhat protective against the production of the Parkinsonism like symptom. Now antihistaminic effect also there. So it produces sedation and it produces antiemetic effect. And antiadrenergic effect is there, which is going to produce postural hypotension and palpitation. So these are the side effect and effect produced by antipsychotic drug. Now they are classified according to typical and atypical antipsychotic drug. Typical antipsychotic drug are the relatively older drug, which include chlorpromazine, difluperazine, haloperidol, flupentixol, pimozide, loxapine. Whereas atypical antipsychotic drugs are relatively newer drugs. They are clozapine, olanzapine, aripiprazole, quetiapine, zotapine, risperidone, ziprasidone, amisulpiride, zotapine. These are the atypical antipsychotic drugs. Now, when we talk about the dopamine theory, it is just a theory, not exact pathophysiology. Why? Because some of this atypical antipsychotic drug does not affect the dopamine system to a very much level, and they are affecting some other system as well, like serotonergic system or some other receptor, and still they are producing antipsychotic effect, and that cannot be explained by simple dopamine theory. And that is why dopamine theory is able to explain most of the problem and treatment of the psychosis, but not exactly the problem and treatment of psychosis. Now, this typical and atypical classification is basically based on how strongly they block dopamine receptor versus 5-HT receptor, and this difference lead to fewer extrapyramidal side effect in the atypical antipsychotic drug, fewer long-term adverse effect, and efficacy in some of the resistance group as well as in they also improve negative symptom. So that is why they are called atypical, because it does not fit our previous description of the typical antipsychotic. Now, mechanism of any typical antipsychotic, we have already seen they are dopamine antagonists, and apart from that they have antimuscarinic, antihistaminic and antiadrenergic effect. Whereas in case of atypical antipsychotic, they are more particularly specific for dopamine D4 receptor, as well as they also affect 5-HT4 receptor. Some of the drug also strongly affect the adrenergic receptor. Side effect, we have already seen that side effect occurs due to two different system affecting different receptor: dopamine due to dopamine antagonism and due to antagonism on other receptor. Antagonism on the receptor we have already seen, cholinergic, histaminic and adrenergic receptor. Dopamine antagonist also we have seen, but we are going to see it in more detail. So dopamine antagonism which lead to worsening of negative symptom, hyperprolactinemia which lead to hormonal symptom, and due to decrease of the dopamine in nigrostriatal tract, it lead to extrapyramidal symptoms. Now these extrapyramidal symptoms are not just Parkinsonism, but they are multiple. Parkinsonism, acute muscle dystonia, akathisia and tardive dyskinesia. Out of this, the last one, tardive dyskinesia, is very important because it is irreversible side effect. It is irreversible side effect. Once it occurs, it even remains there after stopping a drug, so it cannot be reversed. Let's see one by one. Parkinsonism, as we have already seen you have already learned in the ANS, the symptoms include tremor, rigidity, hypokinesia. There is mask-like effects and postural instability. What is treatment? This is the typical drug-induced Parkinsonism. So when a question is asked, which drug can produce drug-induced Parkinsonism? This antipsychotic, dopamine antagonist drug, produces the drug-induced anti-Parkinsonism. Treatment is typically we have to give centrally acting anticholinergic drug. Remember, this has produced because we have given dopamine blocker. So we have already blocked the dopamine receptor. Giving levodopa is not able to produce any improvement because the receptor are already been blocked by this antipsychotic drug. That is why we have to balance it by decreasing the cholinergic transmission as well. So we have to give anticholinergic drug. Second is akathisia. Akathisia is patient become very much restless. Patient is continuously moving around, moving his leg, moving his hand, continuously speaking. Patient is anxious and patient is not able to sleep. 2 day, 3 day maybe patient is not able to sleep. That is akathisia. ગુજરાતીમાં આપણે કહીએ જેને રઘવાયો થઈ જાય એવું. So what is the treatment in case of akathisia? We have to reduce the dose. We can change the drug, and propranolol and diazepam has been found to be effective. Maybe somewhat sympathetic nervous system is involved, that is why propranolol is effective and diazepam is effective. So it is going to produce the sedation and sleep to the patient. The tardive dyskinesia. Tardive means late, dyskinesia means abnormal movement. It is irreversible, involuntary movement of the face and limb muscle. Occurs after many years of therapy and it is irreversible. It remains even after stopping of a drug. And that is why more and more atypical antipsychotic drugs are coming into discovery, because we want a drug which does not produce tardive dyskinesia or produce it as late as possible. Apart from tardive dyskinesia and all these extrapyramidal symptoms, neuroleptic malignant syndrome also occurs rarely. There occurs rigidity, very high fever, patient becomes semi-conscious, and it is a emergency condition. There occurs fluctuation in BP and heart rate. The treatment is immediate stoppage of drug. We have to give dopamine agonists like bromocriptine, and dantrolene can be used to relieve the stupor and tremor which is occurring. So this was the whole problem due to the dopaminergic system blockage. Parkinsonism, akathisia, tardive dyskinesia, neuroleptic malignant syndrome. Now, side effect due to other receptor we have already talked. Anticholinergic going to produce anticholinergic side effect: dry mouth, constipation, difficulty in urination, mydriasis. Antihistaminic effect is going to produce sedation and antiemetic effect, and antiadrenergic lead to postural hypotension and palpitation. Generally, potency doesn't produce much difference in the effect of the drug, but in case of antipsychotic, the potency also plays a role. High potency versus low potency drug. Now high potency means minimum amount of a drug is able to bind to the receptor. So the drug binds very strongly to the dopamine receptor and doesn't spill off to the other receptor. Whereas low potency drug like chlorpromazine is loosely bind to the dopamine receptor, so it is also going to affect other receptor in the surrounding. So what difference is made? When the drug is very high potency, there occurs low antagonism of muscarinic, alpha or histaminic receptor. Whereas drug is very low potency, then it is going to spill over to other receptor, and muscarinic, alpha and histamine receptor is also going to be affected. So as drug is very tightly bound, though it does not produce other side effect, but the extrapyramidal symptom is going to be very high because the dopamine is more strongly blocked. Whereas in this case, this anti-muscarinic effect, antihistaminic effect, as well as drug is loosely bind, it is all going to help in decreasing the extrapyramidal symptoms. So extrapyramidal symptom is relatively less in the low potency drug. But on the opposite end, in case of high potency drug, other symptom of antihistaminic, antimuscarinic or antiadrenergic will be less, where it is going to be high in case of low potency drug. So here potency also defines that which of the side effect is going to produce by the drug. Uses of antipsychotic, obviously they are useful in the psychosis. Apart from psychosis, they are also useful in other psychiatric condition which is called mania. In the mania, patient is becomes very much in the comes in the euphoria and start doing unnecessarily spending of money. Patient may become violent. So they are firstly useful in psychosis and mania. Apart from that, dopamine receptor is also responsible for stimulating vomiting, so they can be used as an anti-emetic. But obviously, because of so many side effects, they cannot be used as an anti-emetic drug. But this point you need to remember that typically which we write that anorexia, nausea, vomiting in side effect of the all the drug. Remember, these drugs are useful in the treatment of vomiting and it does not produce anorexia, nausea, vomiting. So do not write that in the side effect. Okay. Then they can be useful in the anxiety. Some of the antipsychotic are also useful in the anxiety, in the tetanus, and in the alcoholic hallucination. They can be useful in treating alcoholic hallucination. Alcoholic hallucination doesn't occur with the consumption of alcohol. It occurs when in the chronic alcoholic, when alcohol is withdrawn, then alcoholic hallucination occur on the withdrawal of the alcohol in chronic alcoholic. In that case, this chlorpromazine, diazepam and haloperidol can be useful in treating that alcoholic hallucination. Basically they are useful in alcohol withdrawal. Atypical antipsychotic, let's see little bit detail in the atypical antipsychotic and then we will end today's lecture. So atypical antipsychotic, there are many atypical antipsychotic and they do not typically block dopamine very strongly. They also affect other receptors like 5-HT and alpha as well. It is the theory, like in the Parkinsonism, we have seen that dopamine circulate along with the acetylcholine and their balance is important. There is also a third neurotransmitter which circulates in this circuit and that is the serotonin. So some scientists suggest the theory that it is imbalance between the serotonergic system and dopamine system which are producing a symptom, that in some circuit the serotonin is high, in some circuit dopamine is high. So this drug, by blocking various other receptors, try to balance this imbalance between dopamine and serotonergic transmission. They produce fewer extrapyramidal side effects because they loosely binding dopamine. They particularly bind to D4 receptor in more specifically. They also produce less hormonal side effect. They also produce less long-term adverse drug reaction, and they are also useful in treating some of the resistance patients which are not responding to typical antipsychotic drug. They can also improve some of the negative symptoms as well. But even though they does not produce this typical side effect, they produce some of the atypical side effect. They are some of their own side effect. One of these side effect is metabolic problems or metabolic syndrome. What is metabolic syndrome? There occurs hyperglycemia, hyperlipidemia, there occurs weight gain, and there can occur insulin resistance. And these are in a very high level. Like weight gain is patient become really obese. There occurs a increase in cholesterol, increase in glucose. So this metabolic syndrome occurs as a side effect of atypical antipsychotic drug. So whenever patient is on atypical antipsychotic drug, we should regularly check for the insulin, for the diabetes, for the cholesterol, and if such type of symptom is found, we have to adjust the dose or start a treatment for that particular problem. This is the last slide. Out of all atypical antipsychotic, clozapine is very particular in the sense that it is useful in the most resistant cases of the psychosis as well. It can treat many resistant cases of psychosis, but it has some of the more dangerous side effects like agranulocytosis. Number of the WBCs, agranulocytes decreases, WBCs decreases, and patient becomes susceptible to infection. It leads to myocarditis. There occurs inflammation in the myocardium, and sialorrhea. Most of the antipsychotic drugs are anticholinergic drugs. They produce this dry mouth, but clozapine produces sialorrhea, increase in salivation. Exact reason is not known, but it produces the increase in salivation. In fact, so many times MCQ has been asked that which antipsychotic produces increase in salivation. This is one of the only antipsychotic which produces increase in salivation. Apart from that, sedation and seizures can occur. Seizures is particularly dose-dependent side effect. In a higher dose, seizure can also occur. So this was all about antipsychotic drug. Remember the dopamine circuit, mesolimbic tract, mesocortical tract, where occurs imbalance in the dopamine, which produces all the problem. And whenever we decrease the dopamine level in all the circuit, even though positive symptom improves, negative symptom worsens. Decreased dopamine in nigrostriatal tract will lead to Parkinsonism and other extrapyramidal symptoms, and decrease inhibition of the prolactin, which lead to increased prolactin secretion and hormonal problems. And due to blockage of cholinergic, histaminic, and alpha-adrenergic receptor, there also occurs side effect of anticholinergic, antihistaminic, and alpha blockage. Thank you.